Hey, good afternoon. Welcome. It's Matthew Holt. It's THCB gang, a fine gang, somewhat biased towards digital health today, put together. So I'll tell you who we have on. John at Neptune is back. He has a new gig these days at Memora Health. He'll tell us a little bit about that, I hope. A new guest who I've known for a long, long time, but hasn't been on THCB gang before, but I've been on his Bearing.on Health newsletter, Adam Kaufman, who's doing a bunch of stuff. Used to be at Canary Health for many years, was at Weight Watchers briefly, and we'll talk about that. Steve Wardell back from a couple of weeks back with the Digital Health Investor Talk Show, and Vince Kuraitis, our old friend, consultant and platform analyst. So, hi all, great to see everybody again. The good news, I guess, is that the job of Attorney General has opened up, and any of us who have been Venmoing enough young girls can probably apply.
Uh,
All right.
Trump is not worried. There are plenty of incompetent, uh, lecherous attorneys out there. I'm sure they'll find someone to fill a slot.
We'll find somebody who fill a slot. I did have I was reminded today that in 2018 I wrote in April's Fool that I'd been appointed head of the VA because it looked like the British Health Service, and I felt that we were all gonna, I said that either we were, Trump was going to get us into war, or we bit, as soon as if he was out, we'd be at war with Russia pretty much immediately. And the latter part kind of came true. So there we go. All right. Well, let's start the way we normally start. We're now 2 weeks post-election. We did a lot on the TCB gang a couple of weeks back. Had a lot about the election. Obviously, what's going to happen next is a big part of this. But with this group, I think we're going to probably talk a little bit about what's going to happen next with the impact on digital health. So let's go around. I'll end with Adam, but let's start with Vince about what you've been looking at, what you've been thinking about the last few weeks, whether or not
Yeah,
you're applying for the Attorney General position.
I'm not going to talk election. I'm burned out. I'm going to share what I think is good news. About a week ago, the Healthcare Payment Learning and Action Network, or also known as HCPLAN, announced their annual results of what percentage of dollars are paid for by various accountable care value-based payment mechanisms. And they found that in 2023, the number was up to 28.5% of dollars were in downside risk arrangements. That's up 4% from the previous year and up 9% from 2 years ago. Well, that may not sound like a lot, but it is, and let me explain why.
So can I ask Vince, is that of dollars paid to accountable care organizations or
That
of
is
all dollars?
dollars paid by health plans, and they surveyed, I'm going to look at the data here, 200, these are 73 health plans across 283 million people. I consider this the best source out there. So you remember the metaphor of you can't have one foot on the dock and one foot on the canoe with value-based payments and uh, value and fee for service. So Deloitte did a study a couple of years ago, and their analysis was that when an organization hits 40% of revenues, that's the tipping point where it becomes impossible really to maintain fee for service, and we expect exponential growth. So from that perspective, 28.5% keeps getting closer and closer to that 40% tipping point. I understand not everyone's going to think that's a wonderful statistic, but to me, one of the fundamental problems of healthcare is, we pay for volume and we don't pay for quality, and the incentives will shift 180 degrees. So this data is a week old. Hope we can discuss it later, and that's my spiel for the day.
No, that's pretty fascinating actually, because so we're 28% in 28.3% in the canoe. Because well, I didn't bring Jeff Goldsmith on to tell you that value-based care is a myth invented by consultants to make to
I
make
I
money. But
I know.
yeah, I've kind of semi-converted to Jeff's point of view, which is that it's 10 years in the future and already always will be. But there is it does kind of tie into if you the thing that frequent THCB contributor, occasional but relatively frequent THCB contributor George Halverson wrote a piece with Dr. Oz, which I did not know about 5 years ago, about how Medicare for all, Medicare Advantage for all was the way forward, and George is very keen on Medicare Advantage for all. Now, don't forget that not all Medicare Advantage actually pay. In fact, only about 15 to 20% of Medicare Advantage gets down to capitation at the provider level, but there's that. All right. Talking about that, Steven, what have you been looking at this week?
So I'll try to speak about sort of a more sophisticated view of what Trump means for digital health software companies. And I think one that I think people are beginning to realize is that if RFK is appointed to Health and Human Services, he may do certain things that scare pharma. He might block pharma advertising. One of the bright spots of digital health right now is pharma tech. That's software and tech companies that sell into the budgets of pharma, which are the commercial, the clinical, the discovery, and the infrastructure budgets of pharma. And pharma is feeling rich and spendy about tech right now, and that sector is booming. And so this could literally just stop one of the few bright spots of digital health new investing right now. So pharma stops spending on that area because it feels poor, and then investors stop investing in the pharma tech sector. So that's one I think that's been overlooked in terms of talking about the impact of Trump. And then
can I stop you on that one, because
Sure.
I looked and I put something on the LinkedIn there a few days ago, which was, Doximity is what doubled its stock price this year, and it's basically a big vehicle for to directly advertise to physicians. I mean, they do a bunch of other stuff, but all that money comes from pharma advertising. I haven't seen their stock collapse yet. Maybe we should all be shorting it on Steven's word.
Very good point. Yeah. So then, but in general, sort of RFK, is thought he's going to try to sort of put the screws on pharma one way or the other. He'll distract the CEO, the C-suite of pharma, and then pharma won't be spending as boldly on software and tech. So then another impact, I think, is that if there is, under Biden, we kind of dodged a recession. Everyone thought there was going to be a recession for a year or more now, and it's either been pushed off into the future or we dodged it in the cycle, which almost never happens. So I'm going to bet that we are hit with a recession in the first couple of years, and this is bad news for employer health tech. So employer health tech is software, is employers buying, or it's software vendors selling to the employer healthcare budget, and that's things like selling Teladoc or Accolade or Omada or Hinge into that budget. And their employers would like to just reduce spend here. And if we go into a recession, then employers get to spend less on on programmatic health benefits, because employees are not going anywhere during a recession. So you might see that's a sector that's troubled for a number of reasons, and you might see less spending by employers on this sector, which is bad news for the software companies in that sector. And then lastly, I hear optimism about an M&A boom. So Lina Khan was blocking very large transactions, and this caused a sort of a fear in even smaller transactions. But a combination of factors like higher interest rates and lower small company valuations and small companies running out of cash is thought to perhaps trigger a long-delayed, long-awaited consolidation boom in digital health. So there's been over-entry of products, people, capital for years and years, since 2009, basically, in digital health. And there have not been periodic shakeouts and consolidation waves in digital health as there are in other sectors. And so we may see sort of the mother of all shakeouts and consolidation booms in the sector coming up. So those are just some trends, I think, that have not been focused on by others.
Yeah, the last one's interesting, because I keep a track of a bunch of probably digital health stocks, and you've seen a number of people sort of start slowly to weed out of there. Some of the companies that were specced out have either gone out of business or have been acquired, and you started to see a little bit of that, but it hasn't been to the extent where you can tell in any particular space that there are now 2 to 3 dominant players. And if you think about what you said about the employer market, if you look at if you look at Brian Delden's newsletters, oh, my daughter is playing the clarinet next door, so my that's a musical accompaniment to my words. If you look at Brian Delden's newsletter, and when he goes down and looks at employer, the panoply of digital health companies that employers provide, some of these big employers are providing 15, 20, 25 different digital health solutions. And some of the companies are starting to say we can't even, get found within the whole sort of portfolio of stuff that's been offering. I know that Brightline, which is the kids mental health company, is actually pulled out of the employer market, and because they just can't figure out how to get employers to find it. So, JL, you're in Grand Central Station. You also have a new gig since you were last on here. So, tell us the transformation in the Neptune in the Neptune world.
Sure. I'll give you the quick update. So, as you know, for a number of years, I was running a addiction support platform called Central Modern Recovery, and unfortunately, we had to shut that down at the beginning of the year. So I did some searching, and I ended up at a company called Memora Health. And what we do is we build care automation systems for healthcare organizations, and we use AI to simplify complex care journeys for patients and clinicians. And I'm a senior medical director, and talking to customers and doing a lot of growth-oriented work, but also work with product teams and do some client service as well. So that's my story. And then I can give you my news. So
let me interrupt you 1 second. Those long-time THCB readers might go back and find that I did a demo of Memora with Manny Sebak, the CEO, a while back, a couple of years back now. So some idea about the interesting sort of outbound texting from the system to consumers, and then what happens to do the sort of the internal care pathways work. It's really pretty interesting company.
Cool technology backed by Andreessen and General Catalyst. So, interesting company. And, I think we've seen interesting, real need for our solution, particularly amongst customers who are focused on value-based care. And, it's amazing to me, given my Blueprint background, 10 years ago, not too many people were looking for technology to operationalize value-based care. And now it seems like every customer that we talk to on the provider side needs some kind of value-based care ability to implement that kind of payment agreement.
Maybe Vince is right. Maybe it's actually happening.
Yeah.
Sorry, and you were going to say your other news.
Sure. I'll give you my news, and then I'll say one thing about Vince's point. 4 days ago, the New York Times published a study that showed that chatbots outperformed physicians in diagnosing patients. Got a lot of buzz in the news. Over the last couple of days, it's been heavily debunked by our LinkedIn experts, and there's some really good posts about how it's a very small sample size, and it's not a great study. But I think there's two things that come out of that. I think one, I continue to believe that AI technologies, and we use AI, continue to evolve at a pace that is sort of nonlinear, right? And the technology is getting better and better every day. And maybe that one study didn't show how well the technology performs, but I can definitely see in my day-to-day life, how much AI is improving and how powerful it can be to do provider and patient-facing tasks. So I think that's one real thing to come out of that. I think the second thing is, as more and more people read these stories about AI outperforming doctors, I think there's going to be an expectation in the market for patients to say, hey, listen, I'm interested in what does the AI show? I trust my doctor, but I really am interested in what the computer read was. What is the computer saying? And I think we're almost there in terms of the median patient having some interest in the fact that there might be a technology that can also provide diagnostic and treatment information. So I think that's really interesting, and I think there'll be more to come about that study. And then I'll say one thing, Vince, in medicine or in the sciences, we often see what are called sigmoidal relationships. So rather than things being linear, it's sort of flat, and then boom, and then it sort of flattens off. Like the hemoglobin dissociation cycle is a perfect example of that. And I think that that's definitely the case when it comes to value-based care. It's like flat, and then all of a sudden, boom, a huge drive to move in that direction, and then it flattens out again as we hit equilibrium.
Yeah, it's
agreed.
It might be Pleistocene era geologic time, but anyway, and I'm actually interested because as the token doctor on the panel, JL, I mean, do you want to be replaced by an AI computer? I definitely want all my writing and speaking to be replaced. If I could just have the Matthew Holt avatar that knew what I wanted to do, and I could hit the button, it could write the stuff the way I write it and talk the way I talk, or perhaps talk better than the way I talk. You know, I would happily go and sit by the fire and do nothing, and so that but I think there's some real sense of fear, and I was on a Reddit thread of a guy who works in a local TV control room. Those guys in the control room and there are 10 of them, and apparently there's a tech, an Andreessen funded or a Kleiner Perkins funded tech that's going to cut that person down to one.
Yeah, I read that. I read that. Now, can I comment on your question? So what I would say is, like, look, the first problem that we have in this country is that we have a massive over demand for healthcare services that we just simply cannot serve. And Steve Wardell and I have talked about this in the past, right? Like, there are 30 million people who get nothing, or maybe they get emergency room care when they're sick. So if there's a technology that is 90% as good as a doctor and can do some basic diagnosis and treatment recommendations, is there a customer for a product that's $10 a month to get access to that? There might be. So I do think that, these technologies will allow us to deal with some of these workforce shortages that we have and provide care to a much larger number of people and address the needs that we're not addressing now. So that's one thing that I think about the technology. I think the second thing about the technology is it really brings to mind the question of, like, what is the role of a doctor? Is a doctor a supercomputer that just does a bunch of calculations and then spits out diagnoses and treatment recommendations? Or is the doctor the steward of care for individuals and populations? And I think that if we think about doctors as being the latter rather than the former, the technology is less threatening, because it's something that's going to allow us to be advisors, to be stewards, to be supports for people who have healthcare needs at a much higher, in a much more productive way than we do now. And I think that if you could eliminate a lot of, like, malpractice stuff with the technology, I think many doctors would love that, right? If you had a technology that was the backstop and made sure that doctors didn't make mistake, well, maybe there's no more malpractice that doctors have to work with. I have a friend who's a neurosurgeon. He spends $200,000 a year in malpractice insurance. Maybe that goes away with the technology as it gets better. So it can be threatening if you think about certain types of industries that have been AI'd out, that are being eliminated. But I think that being a doctor is more than being a supercomputer. It is being a human being. And I think that this technology will allow us to be more human.
Yeah, actually, and Adrian Allen, who just, his Ford company went out of business, but he when he's been spieling about it, he's kind of been saying that, could we create the product being the knowledge of the doctors, and could the doctor be behind the scenes managing that price? So, he riled up a lot of sellers, and obviously, I don't think his business model made any sense, but interesting. All right, Adam, we haven't got to you yet, so I don't know how we managed to get through nearly 20 minutes without that. But Adam, we met first when you were at D-Life, and then later on Canary Health, where you were doing sort of, I would say, it's not group therapy, but group patient led sessions to improve diabetes care. And then you were at Weight Watchers for a while. What are you up to now? Tell us.
Mostly, excuse me. That's what I get for waiting 20 minutes.
Yeah, sorry, maybe wait too long.
So since leaving Weight Watchers, most of my time has been in interim executive roles at health systems. So I spent a good chunk of time with Mayo Clinic and the Mayo Clinic platform, and have spent a good portion of this year with Baylor Scott and White. So in addition, do some advising. I write a newsletter that luckily we've been able to get your insights, and I went back into the classroom and teach as well. So. And I will say that I have not read the news in 2 weeks. I don't really want to, so I listen to you all for the news that matters.
There is, I think there was somebody advertising that, starting January 20th, you can go on a cruise for like 65 grand a year for 4 years. They'll just take you away if you don't want to deal with it, but I'm not sure that's quite how to do. All right. Well, let's dig in. I think there are a couple of things here that, that are close, which is this idea about, what's the impact of value-based care. And I'll start with, I've hung around with Jeff Goldsmith too much, and I've got cynical about it. But if I go back to when I first started learning about this stuff, which was 30 years ago, more than that, God, 1989 is now 35 years ago. How did that happen? When I first sat in a class with Alan Enthoven, and he explained that we needed to get everyone in these competing groups that look like competing Kaisers. And if we got a universal care platform, and everyone had the same amount of money to go into the system with, that you would incent these different value-based care organizations, as HMOs, they were called them, to compete with each other, right? These platforms, and that they would the point about the technology side was that the ones, like any other business, the ones who would figure out how to better use technology to improve care and do it at a cheaper rate would succeed. They'd be able to they offer insurance, or offer premiums at a lower rate, and they would outcompete the other guys. We haven't seen that in reality. But I mean, do you, if Vince is right, if the canoe, is coming close enough to the dock that enough people can get on, if that's the right analogy, and we're starting to see, moves towards sort of changing how we pay stuff. Again, I'm not convinced that we do, but if we are, does that make life better for digital health companies, or have digital health companies basically kind of said, well, we're just going to go sell to the incumbents, and that, and the incumbents are in general want to do stuff that raises revenue, and we're not too worried about whether it's value based or non-value based or whatever. So I just like us to riff about that a bit as to what do we.
So
what do we
Matthew, if I could take it first. So when we started Canary Health 2013, we started thinking about the idea, officially launched in 2015. We were all in on building tools for diabetes prevention, mental health engagement, exclusively for value-based care. Like that was the thesis, right? Like you're going to get these payments. This is the kind of thing the health system should do. We weren't at all worried about getting reimbursement. I'm in SoCal, kind of the only place where broad-based capitation kind of still exists. So, that's the health system I grew up in. So naively, I was like, everyone's going to do it. Everyone's going to get there. We did get some clients. It went okay. We could talk about that history. But I think since then, the companies, and I would put Omada and then, we all kind of went after that promise. And, those who are still around have retooled to sell into a very different environment, right? I think they, the ones that have gotten scale in virtual care have figured out how to take some programmatic dollars, but bill a fee for service code on the back end. They're delivering, whatever that service was slightly better. So I think my take is it's better because we can do longitudinal engagement. We can provide the gap between the services, and that's what digital can do better than anything else. But I think you'd have to retool the digital health companies that are out there. And so bad for the ones that have figured out how to succeed because they're not primarily succeeding in value-based care, but I think good overall, both for what we care about in terms of better outcomes at lower costs, but also in terms of where digital can play long-term.
What would you say about that, Steve?
I'll just add, I have a big thesis in this area. I'd love to hear people's reaction to it, but it is that that fee for service doesn't like technology, doesn't want technology. It wants expensive people, and it wants to build them at the top of their license. But fee for value wants to get rid of the people and replace them with technology. And so fee for value is great for technology vendors. And it's been, the problem is that we've moved so slowly toward fee for value. And then when you look at the tech products that are sold, often when you sell into a fee for service area, you have to figure out secondary value propositions, and they're in competition with the skilled people who are trying to bill for their own services. That's another reason why it's tough to sell into fee for service. But when you sell into fee for value, you have humans supervising and managing, skilled humans supervising and managing technology, but you just buy more tech over on fee for value. So I'd love to see us accelerate the move toward fee for value, both because it'll accelerate the spending of cash on tech, but also because I think just in healthcare, change is good. The old fee for service system has a lot of barnacles on it, and the new fee for value system doesn't have those barnacles yet. And so just changing to fee for value alone will get rid of some of the old stuff that's dragging the system down.
Can I comment on your question, Matthew?
Sorry?
May I comment on your question?
No, please. I was gonna ask you to jump in, but go on.
I think it's very hard to paint an overall picture. There are over 14,000 digital health companies globally, and we've been deluged. We had a decade of free capital, low interest rates, healthcare technology was discovered. Many of those are point solutions that I think are destined for the ash bin, and there's an incredible amount of duplication among those digital health companies. So I think it would be probably painful for many of these companies that are lingering, but it's probably that better that they just recognize that they're not going to make it. I think there will be a lot of winners, and there will be some winners, and there will be a lot of losers. We haven't had the big washout, and I've been listening to Steven. I think that there is going to be a lot of consolidation, and you pointed out, I think it was John Luke, the under value-based payments, longitudinal care is really valued, and that's where the point solutions don't necessarily fit in. You want to have platforms that offer broad-based services over time, with data, can pull in and share data with whoever they need to. My 2 cents.
Yeah, and I think you're right. The question I think is the retail. I say two things that are problematic in the current system, which may or may not change, right? So one is what Adam said, right, which is that the people who built services that should have fit neatly under health plans or providers that were capitated because they produce better care, the old Canary Health model, and what Memora started, that stuff had to be rejigged to figure out, okay, what CPT code can we bill against, right? And by the way, that might all change, right? I mean, one of the trial balloons that's already come out of RFK Jr. and Oz is talking about changing this, going after. It was more about going after the AMA because RFK Jr. doesn't like them, but their ownership of the CPT codes, but also the RUC, right? The relative value, the resource-based relative value utilization committee. Did I say that right? Which actually determines, and as we know, for years, decades, has been weighted towards procedures and specialists and paying for lower fees for primary care and evaluation type stuff. That might be in question. But ideally, in a value-based care world, you get rid of all that stuff, right? You would say to the organization, you figure out the best way to look after people, and you use the right technologies and people to do it. And you're more, like I said at the start, if you can deliver the care for better and charge less, you should get more market share, etc. That's one thing. So I think that's a question: is can you retool those guys? The other side is there's still a ton of, when I look at money being invested, there is still a ton of stuff going into things that look like, can I fix prior authorization? Can I fix, being on hold? Can I fix the providers? Can I use an AI tool like Infinitus that will call up on behalf of a provider using a bot to, to deal with some admin issue, that really shouldn't exist, but is still there. And there's a ton of very, very smart people doing revenue cycle management and arguing about the 3% difference. Should it go to the provider? Should it go to the payer? Or can I squeeze my little bit out of the middle? Not
Matthew,
to mention, go on, Adam.
I'm not as convinced, even if you were 100% value-based, that you'd get rid of a lot of what you're describing. Because you've got, I think, an idea where the payment is flowing directly to the provider. They're delivering all care, which not even Kaiser does, but almost no one else does. When you have subcontracts and subcapitation, it gets wonky. I was shocked. I did a project for a company exploring selling into value-based care in cardiology. So it turns out very few cardiologists are in value-based arrangements. We could talk about why. But interestingly, the few that are actually have a shorter time horizon than the ones who aren't. Because the way the contract is worked, when you deal with attribution to the plan, to the capitated primary care doc, to the cardiologist, they turn over very quickly. And so the mechanics of how value-based care work have a lot of the same underlying problems, and we haven't dealt with them at scale. And unless everyone is going to be Kaiser and employ everybody, we're going to have a lot of this, like, well, did you subcap this group, and who gets what rate, and how does it go? And so some of that's going to be there no matter what. And so I don't want us to think it's, in my opinion, a panacea, because it, like, even if you capitate the primary care, what do they do to the hospital, and do they take people? I mean, so there's a lot of nuance in full capitation actually playing out.
It's just another Gordian knot to deal with, right? There are like so many problems and so many questions to be answered that I think we are moving in the direction of, like as Vince said, I think we're moving more to that canoe, but there are so many questions to be answered about, as you said, right? Like how do you pay specialists versus primary care, right? How do you think about facilities reimbursement? I mean, there's so many questions there to be answered.
Joe, you said earlier that you felt for Memora when you started getting into. I know you haven't been there very long, but when you started sort of digging into it a little bit, that there was more of a sense that value-based care or people who were somehow being scored on that were more likely customers. But from my recollection, Memora's in a lot of hospital systems, and most hospital systems still are not. They're still on the dock compared to Vince is getting in the canoe. In general, I know that there's complexities with them having ACOs and having different contracts and what have you. But the kind of stuff that was being done, is done a lot of in terms of managing a population. If you talk to Bob Walker at UCSF, there's all this kind of management going on of people with diabetes. If you talk to the Mayo people, who are still basically a fee-for-service organization, and obviously you know this well, Adam, they've been building care pathways and guidelines and trying to get their people to play nice with that, in their sort of culture and it's a salary-based culture, a salary-based payment system, but not, culture. So do you not think that, and this is where Jeff, if he was on, Jeff Goldsmith would be on this one, he would be saying what we need to get to is basically the professionalism of doctors to manage this whole process and do the right thing and let's get out of their way. Do you think there was, when we were looking at what Memora's been doing, do you think there was any of that happening anyway within the traditional system, or are we all waiting for fee for value, which, as Adam just said, is going to be a lot more complicated than we might like?
Sure. So remember, as physicians, we do care about quality, right? And whether we're getting paid for it or not, the typical physician cares about the quality of the care that they provide. It's part of our professional ethos. But I think that in the past, that the quality didn't really drive how much you got paid, right? Like there was no downside risk, there was no upside benefit to providing better care. And I think what's changed, and certainly in many of the customers that I talk to, is how many of them are exposed to these value-based agreements that impact the bottom line, right? And I think that there are so many different types of agreements. So there's a great deal of heterogeneity. And that's also part of the challenge for payer organizations, is that you might have 50 different quality programs that you have to manage all at the same time, which is really, really hard. But I think, again, the difference here is that now we're talking about financial impact from this move to quality. And I think people are taking it much more seriously now and thinking about how do we actually move the needle for all these different programs that we're exposed to.
Adam, can I ask you, I mean, just to pick up on the two you worked for most recently, but Mayo, which is this kind of odd beast out in American healthcare, and then you have a big system based in Texas, right, which is not thought of as being Southern California. What kind of talk about the heterogeneity that JL mentioned about sort of quality programs and how payers have to deal with it. There's also in those different markets, and I picked Texas because I know it's got, there are a few big Optum clinics there as well. What would you say is the differential between, that you've seen between how this gets approached? This idea of, do we have to can we go to these sort of big care guidelines? And
if you ask me, I think there's three big strategies that health systems are pursuing, and then a fourth, which is we don't really have a strategy. But when they have the resources and the capability, this is how I do it. I'm happy to bug it. So I think there's we're just going to be the best. And I think that is clearly Mayo. It's probably what UCSF wants to do. There's a small number of systems that we're just going to win because we are the best at whatever that is. And typically that is the bleeding edge. And they care about cost, but it doesn't really matter. And Mayo will say, we will treat everybody, but we'd actually prefer to treat someone who can't be treated somewhere else. Like they will go out of their way to talk about that. So I think that's one strategy. I think there are a number of strategies I'd probably maybe put, and I don't know them as well, but I think Novant is one of the ones pursuing broadly a value-based care. We're going to do population management. And I think there's a fewer amount, but I think Baylor is squarely in the camp of pursuing we are going to be customer-centric. And it's very interesting. They're not inconsistent, but they're very different strategies to say, I care about customer loyalty and value-based care. And they're not the same. And actually, surprisingly, very few health systems think about customer loyalty. And so what I would argue is, while I'm a huge proponent of value-based care, I think it makes sense. I actually think the combination of the system becoming more customer-centric and to what JL was saying about the just sheer lack of clinicians in every area is actually going to reorganize care more like what we want, because there just aren't enough clinicians to see everybody. Some of that may be those who can afford to pay cash, some may not. And then this idea that I'm going to lose my patient to somebody else and I'm only going to have the people that Walgreens decides to send me for my services, I think is going to force health systems to think about engaging people longer, which is part of what we want in value-based care. But I think it's coming at it from a different perspective of trying to be customer-centric and deal with, in a business sense, lifetime value of a patient.
To comment on that, Adam, I've seen statistics of how much leakage there is in a health system. I mean, how many people utilize more than one system, and then the numbers are something like 45%. It's amazing. And so the customer-centric strategy is one that of few that actually makes sense in a fee-for-service environment, and it makes sense in a value-based care
And Vince, actually, if I could, what's really interesting is, and I think it's attributed to Baylor, but I'm not sure. But if you ask the physicians, they're full, right? So from a like, is my day-to-day full? Because there's just not enough doctors of any kind, of almost any specialty in any GR, except for some of the like overdone, and like, so they've never thought about loyalty, because while the patient doesn't come back, their next day is full. So it's actually a rethinking to what we'd want, which is a longitudinal relationship with the individual where they feel enough value. But to do that, you got to deliver value. So I agree. I'm agreeing with you. I'm just saying historically, it has been, is my operatory full? Not did I get the surgery from the patient who saw me a year ago for something else. That's not even a measure most health systems have on their dashboard.
Lifetime value of customers is measured in so many other industries. The cell phone company knows how much you're going to be worth to them over 5 or 10 years. That terminology.
And certainly a share of wallet even further. Like a grocery store will tell you what share of wallet they capture. Like they know how to do that. Health system has in general no idea to tell you the share of care that they're got in a given year from a family.
The terminology isn't even there.
I had lunch with a guy who runs a very large telehealth, sort of mix between Teladoc and a mix between, I would say, Teladoc and ZocDoc in terms of it does primary care, but also refers out and gets a slice of the referrals in India. Yesterday, the biggest one, a company called Practo in the Indian market, and he said, I was just shocked that American hospitals spend more on IT than they do on marketing. And I said, well, they do seem to market, they seem to advertise on every sports arena I've ever seen. But I guess you're right. I said, but on the other hand, the IT thing also gets them paid, right? They do their billing via that. But there is something to be said for what you just said, Adam. And I think no, I'm blanking on the name of the company. Is it? Oh, I've also interviewed both the CEO and the company who escaping my but it was started at Baylor. The guy who
Amenities.
Thank you, Amenities.
Yeah.
What's the guy's name?
Awesome.
Yeah, awesome. Yeah. He I think he started at Baylor, right?
Yeah, he was there before I was there, but came out of that same idea of becoming.
But his goal is to build a sort of front end that would allow more services, primary care and whatever else, to be added by systems to do more customer-centric stuff. And funnily enough, on THCB yesterday, Seth Joseph, who normally writes on Forbes instead, for whatever reason, was unable to publish a piece about Epic and their strategy towards my health, my chart, sorry, which was exactly this topic, right? Epic making it a little trickier for systems to start using their own version of my chart, or build on top of my chart, and what their strategy was. But again, the issue that, and I think it's been raised by a couple of others, that you have 5 or 6 different portals.
If you allow me, I'm curious, and maybe Steve, I know you want to say, so I could prime you with a question and you could pick it up. I think if you had asked the health system 6 months ago what Walmart was doing, what Walgreens is doing, like all of the clinics out of essentially retail businesses in healthcare, scared them into this. Those have not been successful. Steve, I'm curious your take on that particular, because it wasn't a value-based care, it was a sort of a low cost, but like your take on what that is doing to the industry broadly, and particularly digital health, the sort of lack of success of the retail clinic.
Yeah, so the world of pharmacy is just reeling right now on a number of fronts. And one of them is that for CVS and Walgreens, these convenience care at CVS and primary care medical practices at Walgreens didn't work, and they're retrenching from these. And I haven't heard, and also Walmart. Now, Walmart was an interesting story, probably different from the others. With Walmart, when you add a pharmacy to Walmart, the sales in the rest of the store per square foot go up. When you add a prescription eyeglass care center in a Walmart, sales in the rest of the store go up. When you add a primary medical care practice in a Walmart, sales in the rest of the store don't go up. So that's why they got rid of the primary care medical. It doesn't have to do with convenience care. It doesn't have to do with making care accessible. It doesn't have to do with that. It's just that they had, if they can find something that makes their sales in the rest of the store go up, then they would obviously use that instead. But with CVS and Walgreens, it's not clear why, but this is a major, this is undoing like 10, 15 years worth of direction. And it's a huge loss for the consumer who was promised kind of accessibility, convenience, and low cost, in their neighborhood. Most doctors' practices, you have to book, you have to wait, and somehow these felt a little different than that because it was going to be on your shopping trip anyway. And so, and it's not clear why, but definitely a shock that this is all happened in 6 months. It's bad for consumers. It's good for the incumbents who are not doing this probably because it forces people down the traditional channels.
Dave, I'll answer Adam's second part of Adam's question. What do you think that means for digital health companies overall? And let me give you a flavor of that. One of the things we've been talking about with value-based care, plus digital health, plus lack of clinicians, is the creation, and particularly mental health. And I just came from the BHT conference that Sami Tabibu runs, where you now have real provider groups set up from whole cloth with huge amounts of financial backing to set up, psychiatrists, psychologists, coaches, all that stuff. I'm talking about Lyra, Brightside, on, psychiatry, a bunch of companies in that space. But I mean, you're starting to see some of that in some of the specialty areas. You see a couple for migraine here and there, Ocean in digestive health and GI and a few others like that. Do you think that because of the lack of access to clinicians that we're going to see more growth in that space? Or do you think, we got mental health and that's about it because there wasn't an incumbent, there weren't really national or big regional incumbents the way there are in other traditional provider organizations?
So I'll take a shot at that. So I think that this sort of failure on the part of the drugstore chains to do primary care, it reduces accessibility of patients to care. I think to a certain extent, it may indirectly enable technology between the physician and the patient. So in order for existing physicians in traditional settings to see more patients, they may use technology. And in order they may shift more to video care because they're also less convenient than it was to go to a drugstore and there just isn't the access. So they may do more video visits. So in an indirect way, I think this makes care less accessible, and that enables it sort of forces providers and patients to use more tech to solve convenience and access issues. I think because the medical care place on the corner at the CVS isn't there anymore. So that's just but I think that's a relatively indirect effect over time of just sort of pressure of both providers and patients feeling inconvenience and being willing to do tech steps. And this is consistent also with with more and more percent of the population is sort of a digital tool native and is happy and comfortable. Young people expect their care to come from their phone, not their doctor's office, and so more and more people are willing to do a meeting on an iPad or whatever. So that's
I'll agree with 90% of what you're saying, Steven, but the 10% is I don't see that patients really are going to care that the Walmart urgent care center is gone. I mean, there are other urgent care centers all over the place. And I think one of the lessons from retail failing is that in most cases, people would prefer to see their own doctor. And when you can't do that, there's urgent care and there's telehealth. And, the fact that Walmart isn't there, I don't know that most people are going to care.
I'd just jump in and say that the other lesson from this, from both Walmart failure and Forward, failure, if you ignore the last bit of when Forward was creating the weird pod thing, which a number of people have tried and never seems to quite work, is that if you isolate primary care from the rest of the system, there's no way on the current payment structure you can make enough money on primary care to make it work. I
Yep.
mean, maybe it could have been a loss leader and generate more, spending per square foot in Walmart. I don't know. But in terms of, if you, the old lesson from Kaiser is that and for that matter from Iowa and Oak Street and others, is that you have to spend more money on primary care to save money in hospital admissions and pharmacy and all this other stuff down the road. And it's very hard to do that. It's a whole culture change, as we know. And whatever you can, maybe we'll get some changes in the future, right? Maybe we'll get maybe this assault by RFK Jr. on the AMA and CPT codes will, and Dr. Oz putting us all in Medicare Advantage or whatever. That's very much a maybe, because that the administration is, as we've already seen today with Matt Gaetz, whatever his name is, having to pull out has been pretty much will be a shit show for another 4 years, I suspect. But you could imagine if they really are determined and they have the concentration and really care enough to take a whack at this, they could change that. But on the other hand, it's the only one that succeeded, as Adam said, has been Kaiser. All the Kaiser imitators that were all set up in the 80s, back under the days of HealthNet, which probably, I don't know if Adam's too young to remember HealthNet, which used to be part of Blue Cross of California. That's a funny story.
It's part of Centene now, right?
Yeah, I think it is. Well, anyway, but it was set up by Blue Cross of California to compete with Kaiser, and they set up those medical groups like Friendly Hills and Mullikins, back in the late 80s, right, to take capitation. Other than those ones, right, you tend to need 20. The way you build that primary care based capitated system is to have 30 years of culture. Right, which is pretty hard to
pick up on my theme though. So we're Kaiser members. We love it. My wife was very skeptical. We've had great care, but the first thing that said I need to be at Kaiser, my daughter forgot her sweater at the doctor, and they mailed it to us. That is customer service. That is not like Kaiser actually. You feel like a Kaiser member. It's there, like it's not just a care model is the main thing I'd say. And what I've learned having come at this from the value-based care is that works when it's customer centric as well. I don't think those are competing strategies, but they are different lenses. And I think they end in the same place of someone who has a longitudinal relationship, is engaged in their care, and a system that is incentivized to do that, whether they get paid on each visit or they get paid at the end, to keep you part of that.
You have to create the cult, right? The NHS does the same thing.
Yeah. You can say. I think that, just to finish it through, and then I will stop talking, but I think one of the things the retail clinics were doing was there were two responses. So Rush, for example, said, we're not even going to try to build a front door. We're just going to let CVS navigate people to us, and we're just going to do procedures. And I think that was a potentially bad outcome that got us even ironically more fragmentation. Baylor looked at that and said, we can't lose our client to CVS. We've got to go upstream and interact with them in a way that we won't get disintermediated. We could talk about, I think there's an equivalent story on the employer side, and then I'll be quiet, is like, what is Transcarent going to do, right? Where you own these centers of excellence, you become the navigation. Is that actually good because someone's steering value-based care better? Or does that actually disintermediate the health system even further? And it's a false promise that you'll get a better outcome at a lower cost.
Yeah, interesting. Actually, do you have a view on that, JL? Because you've looked at, I don't know how much you looked at Transcarent, but the reason I bring it in is they've now decided the way to fix the lack of people problem and the lack of access problem is to have a very smart AI navigating tool. Although you can't call it a navigator because Glenn Toolman doesn't like the expression, but it is a navigation tool. JL, do you have a thought about
that? So my thought about this goes back to what I was saying about what we were saying about LTV, what we were saying about what's the relationship between a patient and a provider. And I think what the lesson that's been learned at Kaiser and at other places is that relationship-based medicine is cheaper medicine in the long run, right? In the sense that once I get to know you and I really get to understand you and you get to trust me and we are practicing in a fundamentally different way, we can really start to bend the cost curve, right? And I think that so much of healthcare continues to be much more transactional, right? And I think that a lot of, you can even argue that those clinics at Walmart and at Walgreens and CVS, they were still transactional medicine, right? Like you go in there, you go get your thing, and then you disappear, but they never could really move the cost of care. So I think the deepest lesson here is that, you need to have relationships between patients and providers that span years. And if you start doing that and you're practicing in the right way, you can really start to bend the cost curve. And I'll just give you one example here. I am the doctor consultant for a group of friends and family members, right? They know I'm an internal medicine doc, and I get calls and texts all the time. And I get to sort of build that relationship with people. And I have, on many occasions, told somebody, don't go to the ER because that's not exactly what you need. I would recommend, given that I know you, this is what I would recommend instead, right? I do that on a micro scale. Kaiser does that at the macro scale. And I think that that is really the way, at the end of the day, when we think back to all these different models that we try, it's really going to be a relationship-based model that drives the lowest cost of care over time.
So hopefully, JL, you're sending him a text back and a Venmo request at the same time.
I should,
you should be. If you send out enough Venmo requests, you too could be Attorney General. Although it's the wrong way around. I mean, but something like that. So yeah, no, I mean, I think that there's a lot to be said for that. And if I go back to Arnie Milstein, sort of classic, doyen of medical directors when he was working at Mercer and Stanford and elsewhere, I had him on a Health 2.0 stage a while ago, I want to say 2012, 2013. And he looked at a whole bunch of low cost areas of the US. And I said to him, what's the difference? He said, well, what do they do right? Why were they cheaper? Why was this metro area cheaper than the one, 50 miles away when it's basically the same kind of people, same state, whatever? And the answer was, well, there was a bunch of stupid stuff that happened elsewhere. There were a few doctors in the network who were prescribing too many opiates, or there were too many back surgeons who were doing fusions or whatever. But once you kind of got rid of all that, the issue was that majority of patients in those regions, in those metro areas, when they were surveyed, felt that they had a relationship with their doctor and their doctor cared about how they behaved. And I'm actually doing a little work with a tiny company called Med Incentive, which is trying to sort of create that effect, build that relationship and do quizzes and whatever and prescribing and open up the doctor to seeing whether the patient read their material and understood what they're doing and committed to doing it, and that kind of, building that kind of effect with trust between them. And I thought that was really great. And I remember in that audience, I don't know if you were there, Joe, it was 12, 13, I can't remember whether you were with us or not at the time, but I remember in the audience, I stopped Arnie and said, okay, Health 2.0 audience, and there were probably 400 or 500 people. It was one of our smaller conferences, not the big full one. How many of you in the audience think that your doctor really cares about how you're getting on? How many hands went up? I mean, I think like 4, out of
But by the way, Matthew, I'm incredibly bullish on tech to enable that at scale that a human being couldn't do, right? We're just not naturally as good as doctors at tracking longitudinally what happened, being empathetic all the time. And so if you run through a record that keeps track of it, you run through AI that generatively writes, I actually think we will platform, and then particularly for a consumer, to Steven's point, that's willing to interact with the phone first, I think we'll platform healthcare eventually. The question is how soon. But I think what we're saying is that is somewhat independent of payment model.
Yeah.
Right. The payment model is a nice thing, but my mom was a pediatric endocrinologist, got paid the same amount herself, and the hospital did or did not get paid for most of the patients, and she practiced that way. So it's not anyway.
And Matthew, you could argue that the sentiment that my doctor cares for me is a proxy of how good the relationship is, right?
Sure.
And how much that patient has developed a relationship with a provider that then allows them to have good access, get their questions answered, get the care that they need.
And actually, let me put one word of warning. So also, I'm now doing Health 2.0 Greatest Hits. 2015, I think I had Marcus Osborne, who was at that point in charge of Walmart's sort of move into primary care. On stage, and I said to him, why did you guys do this? Why is Walmart, known for selling cheap Chinese goods, soon to become more expensive Chinese goods, I guess, with the tariffs upcoming? Why are you doing this? And he said, well, we surveyed people coming into Walmart, and 50% of them said they didn't have a primary care doctor. Oh, no, sorry, 30% of them said they didn't have a primary care doctor. Then we surveyed the other 70%, and 50% of them, i.e. for another 35%, said they did, but couldn't name the primary care doctor, which indicated to us that they didn't have a good relationship with them. So we felt there was a huge, so they were trying to build kind of that relationship, albeit between, a big corporation like Walmart as being the primary care doctor. Now, clearly there was a lot of problems, it didn't work, whatever, but it does indicate that need. And I've argued with a bunch of people on the therapy mental health side in public and been shouted down that I think, especially for stuff that is conversational, and you look at what's coming out of NVIDIA and some of the companies building these types of tools, that you're very close to a lot of the things happening in therapy and elsewhere being fine, being 90% good enough, as I think you mentioned, JL, with a bot. Now there is issues around laying the hands on exam, the rest of it, but I think a lot of the rest of that stuff, including some stuff like cognitive behavioral therapy and other stuff that's relatively well routinized, could work fine. And look, honestly, your new-ish gig, JL, does kind of a lot of that stuff, right? You're
For
texting
sure.
people back and saying, hey, this is the place you should be in the care guidelines. If you're not, can I route you somewhere else? And if you are, keep going, and taking a lot of that mental load off the provider, who probably can't manage it anyway, and also tracking where people are. They're doing the messaging, managing, monitoring stuff that I talked about 10 years ago at Health 2.0, which didn't quite happen as quickly as it should have done.
And Matthew, just to give you a number on that, it depends on the use case for us. But in terms of inbound texts, for us, we find anywhere from 50 to 75% of texts can be handled by a computer, and a response can be driven to a patient via text, as opposed to that patient having to make a phone call, walk into the emergency room. I mean, if you would have asked me 5 years ago about AI in healthcare and patient-facing applications, I was very skeptical. But I think with the emergence of ChatGPT, the emergence of these refinements in AI, I think we're getting there.
Yeah, and I think just to add, last week I had Robbie Pearl on solo, mostly because when I have him in a group, he drives everyone mad. Don't listen to that part, Robbie. But and he's just written this book, ChatGPT MD, and he basically said, look, we tried to do management of people with chronic illness, but we had to do it by humans observing, and it was just too chaotic and too expensive. But the large language models can do it. You can feed in all this data and they'll spit back what you should do. And I'm sure all of the companies that either you're observing, working with, part of, or hosting as a customer, Adam, are moving towards that, because it's just so obvious.
I know we're short on time. I'll pitch you
but this is a podcast. Now I understand that 78 Americans listen to Joe Rogan for 3 hours. We could be here till.
So I'll pitch you a topic for next time.
Yeah,
which is the derivative of that. It's not apparent to me now, if I put on a digital health company hat, how I continue to build competitive protection and differentiation for those algorithms. So I actually think we have a coming separate challenge, which is, okay, those are doable, but who's going to own them, and where's the value going to get derived?
I completely agree with that one, and that's interesting. So if you look at the place where AI has been grown the fastest in recent years, which is ambient scribing, right? You started off with a few very specific companies, and still are specific companies, who've taken large language models and molded them extensively and made them for healthcare and whatever. And now everyone and their dog has got an AI scribe, and some of them are being offered for free.
Yeah.
And it's hard to say that the ones that are very expensive, a la, DAX from Nuance bought by Microsoft and Abridge and others, is so much better than the ones for free, that you're not going to have the sort of reduction to the mean, which is basically Claude or ChatGPT.
And ironically, I think it's even worse in the regulated algorithms. If you look at care, because as soon as you have FDA approval, I don't know if the market cares if yours is slightly better than the other one if it's FDA approval. And so why would you pick one autonomous image reading, diagnosis software there? It's just ease of implementation and cost. And the second mover is much cheaper than being the first one to go through FDA and the first one to get. So it's not clear to me how other than distribution and just scale, which is, Steve, I think you've talked about this before, that's actually the defense of a lot of digital in general, but we're just not used to it in healthcare, right? So I think we have a kind of a different basis of growth and competition, and it's hard for software companies. I haven't seen in a while, Stephen, maybe, what percent of all global profits accrue to a very small number of software companies, right? That's different from 14,000 digital health companies. There'll be four. And there'll be Microsoft and Amazon and two others, right?
Steve, Adam's asking you why you will still have a job in about 10 minutes.
Yeah, well, so big picture, software companies in general are very profitable, but high margin, fast growing software companies have massive market caps. And so there's an odd, and then AI companies all tend to be earnings negative right now. In fact, there's a joke that NVIDIA currently has 250% of the profits of the entire AI sector. But software in general is very profitable. Digital health software companies and digital health service companies when they're young, tend to be not profitable and need venture funding. And it's a little concerning how few of them have come through the other side of that and come out as strong, profitable companies.
I'll go back to Doximity, right, which, by the way, was profitable very early on, raised $50 million from Rebecca Lynn at Canvas Ventures, never spent it. If you look at their S1, they're sat on their balance sheet. Their balance sheet never went below 50 million after they raised that. So they gave away a decent chunk of the company, several $1 billion worth of IPO for 50 million they didn't need to take. I'm sure it was reassuring to them they had the money there if they needed it, blah, blah, blah. But, but don't worry. Steven's just noticed that, mentioned at the start that their market cap's going to evaporate as soon as everyone figures out that RFK is about to ban all pharmaceutical advertising, marketing, and everything else. All right. As Adam noted, we are kind of at the close of our hour. That was a real fun discussion. Great having all of you on. I would just want to quickly go around as ever. And you, well, not as ever, you don't know this, Adam, but everyone else knows this at the end, and ask you what you're looking at next. Do you think it's going to surprise us? And what do you think is going to happen in the next few weeks and months that you've got your eye on? So I'll start with you, JL.
I'm just looking to the nomination process for Mehmet Oz. And, I think of all the candidates so far, he seems to be the most viable and the most competent. And I think he will probably be, despite his past, pushing pseudoscience on his show. He is a real doctor. He is a real cardiothoracic surgeon. He's also a Wharton MBA, which is interesting. But I think he will receive confirmation. And it'll be also very interesting once he is confirmed to see what he has to say and what the plan is. And I do think it's going to be, acceleration of Medicare Advantage, more, he's talked about that before, and expanding Medicare Advantage coverage. And we'll see what happens from there. But that's what I'm interested in.
No sucking up to a fellow Columbia MD and Wharton MBA by any chance.
Before he started the television show, he was a very, very well-regarded cardiothoracic surgeon, a real pioneer in LVADs, like a real star. So, he is a real doc.
And also, he used to do the stuff with Michael Roizen about, diet. So some of the stuff that's, that has been second, is not controversial, right? Is that we eat too much processed food and we should have more natural stuff, and we eat too much sugar and yada, yada, yada. And he was, with the whole wellness stuff with Roizen that he was involved in that as well. I don't know what happened to him after the TV show and all the supplements and stuff. I don't know where he lost his bearing, and then, I think he'll get confirmed. I think probably, but we'll see how far he goes down the path of trying to mess with CMS, and the idea of how you move that massive ocean liner, with a couple of small tugboats is going to be interesting. We'll see, but that is the interesting one. I don't know. I think RFK Jr. is nuts, but that's a separate issue. Vince, what are you up to? What are you looking at?
Yeah, so a couple of years ago, I quit Twitter. Twitter had a great sense of humor. LinkedIn is not bad, but it's a little stuffy. This week, I'm trying Blue Sky, and my personal experience is really quite positive. I think it's overrepresented by the science community. There's a ton of doctors on there. There are a ton of journalists on there, and the user interface is really quite good. So I'm hopeful it will continue to grow. Jean-Luc, I wish I could share your optimism about Dr. Oz, but I can't. I'll just leave it there.
That's okay.
So I've got to tell you, I've had my first, I too, I'd signed up for Blue Sky a while ago, and also wanted to, there's other platforms. This is the one which seems to have Fred's, but Fred's insisting on using your Instagram name, and I don't really have much of an Instagram account. It's kind of disheartening when you're followed by 28,000. I have two accounts on Twitter. One has 28,000, and the healthcare blog has 35,000, and now I have 300 followers. And so it's disheartening to say, well, that was good 15 years. And I would rather some benevolent billionaire bought it off Musk, turned it back into a nice non-profit. It's not going to happen, but that's what I was hopeful for. But that's disheartening. I haven't had my first person. I think I made a quip that someone was talking about Medicaid cuts and how they were coming. And I said, oh, don't worry, that's okay, because Medicare recipients are poor. Most of them aren't white. Most of them live outside swing states, and they don't vote anyway. And I was the first person who came back and said, you should mark this as sarcastic. So the first person who didn't have a sense of humor about what I was saying or thought I was a nut job white nationalist, but who knows, maybe I might be. So anyway, but yeah, Blue Sky looks interesting, and there's been some good chat. Right now I'm doing both of them. I haven't despaired completely about Twitter, not the least because I have and this is a bit like if you were to move off Gmail or something, I have 15 years of memory. So didn't I tweet something like that? And I'll go search Bolty Boy and some obscure thing, and I'll come back with this thread that I tweeted 6 years ago about something, and I'll turn that into a blog post. Maybe I need an AI bot to go do that for me on Twitter. I don't know. Maybe Grok does that. I don't know. Adam, what are you looking at? What are you thinking about?
I think it's where we started. I just curious to see how funding goes, what actually happens with more companies closing, what happens with the acquisitions. I think the last two times we've had administration changes, things just got slow, and this is a tough time, I think, in digital health in general. So whether it's that coming merger wave we talked about, or more companies just closing one day to the next, like forward, I think that's what, at least for the next couple of weeks or months, what I'll be watching.
All right. And Steven.
So looking at a couple of things. First, as I mentioned before, will we see a recession? I think this recession is bad news for young software companies in digital health on a couple of different fronts. Then will we see, and this is partly dependent on whether we see a recession or not, will we see the IPO window open up? So we had some filings by Omada and Hinge. Although last I checked, they had not filed their S1s yet, but it indicated that they're exploring the market and they're overdue for IPOs. And so that would be very good for young digital health companies if the IPO market opens and if companies trade well. And then lastly, I think a continuation of the boom in early stage investing in AI in healthcare. So this is a well-known phenomenon, been going on for nearly 2 years. It continues very strong. I saw a number, someone came out with a number that 40% of fundraisers that are announced are for companies where digital health is core to, or I'm sorry, where AI is core to their product. And I think that's going to continue. And there's sort of like two worlds out there in digital health. It's like first class with champagne service is if you have an AI product, and then coach, where people are standing in the aisles and holding on to strap hangers, is for everybody else in terms of fundraising.
Are you flying Singapore Emirates up the front, or are you on Spirit or Ryanair at the back in the digital? We need to get a cartoonist to draw that and allot those logos to the different compartments. I like the image. I too am very fascinated. I hope those S1s happen. I mean, for God's sake, Omada, Sean and Crow. It's been it's nearly been 15 years. Time to send your investors some of that money back if you can. And that will help everyone. I do worry about, and I've written this up a couple of times, that there are all these other companies sitting there on the public markets who are, pigs in the ditch getting in the way, and they need to be cleaned out somehow. And I don't know how that happens. Maybe we'll get some more M&A first, but these things are sent to trust. But you've got to imagine if they can't get, with the stock market, this incredible frothy high that it is, and trading super well, and AI at these ridiculous P valuations. You've got to imagine if they can't get out now, if there is said recession that you're rightly worried about, that door will slam horribly shut. So we will have to see, and fingers crossed for the digital health sector and any of us having a job in the next few years. So we'll continue this in the homeless encampment or wherever we will end up. All right. Okay, and with that, it is time for us to go. You have been listening and watching to the THCB gang for November the 21st. You've been watching JL Neptune from the future immigrant exclusion camp of Manhattan, which the Homeland Security will soon wall off and deport all of you wherever you
escape from New York.
It will be Escape from New York. You can play the Kurt Russell guy with the iPad.
Snake Plissken.
Didn't they also do Didn't they do Escape from LA? Because Adam Kaufman.
They did.
Yeah, you guys can both, when they can. There are of course more undocumented and documented and vaguely documented immigrants like me in California, most of them in Los Angeles area than anywhere else. So same thing will happen. But don't worry, Gavin Newsom will have the California National Guard facing down the ice. It'll be very interesting, constitutionally and politically as we go into Civil War #2. Steve Wardell from the bluer than blue state of Boston, of Massachusetts in Boston, and Vince Kuraitis from the redder than red state in the bunker in the wilds of Idaho. That was THCB Gang for November the 21st. Thanks for listening to us. Hit that subscribe button on Apple Podcasts or Spotify or the YouTube channel, and obviously come back to the healthcare blog. And if you're not on the mailing list, go sign up and please get on it. And we will talk to you all shortly. Thank you very much for listening.